Welcome to the Trauma-Informed Lens podcast. I'm your host, Matt Bennett. Each episode we talk about the research and practical aspects of the trauma-informed movement. This podcast is not designed to replace mental health services. If you feel uncomfortable or triggered by our discussion, please consider seeking your own trauma treatment. In no way is seeking treatment an admission of weakness. It is a chance to build resiliency and experience post-traumatic growth. You can find show notes, resources, and more at traumainformedlens.org. Welcome, friends, to the Trauma Informed Lens podcast. I'm Matt, and I'm here today with my good friend, Dr. Liz Frye. So, Liz is both a brilliant thinker and just from a harm reduction, street medicine, street psychiatry perspective, I really think one of the leaders I want to throw out in the world around street psychiatry and just how we approach people living in with a lot of mental illness, living on the streets, rough sleeping, and her work, her mind is just a treasure for those of us that get exposed to her. So I'm excited. Liz and I are going to talk a lot about harm reduction today, which is, I know, a new topic for the podcast, even though we might have mentioned it a few times in there. So I'm excited to dig deep with you, my friend. But Liz, give our listeners a little bit of introduction about yourself and your passion for street medicine, and what the heck is street psychiatry?
Yeah, thanks, Matt. I really appreciate it. Hopefully I'll live up to all of those things that you said about me. So I identify predominantly as a street psychiatrist. And what that means is that my preferred job is to go outside to where people experiencing unsheltered homelessness or rough sleeping. So going outside to provide psychiatric care to people sleeping on the streets, under bridges, in encampments, basically any sort of, I guess, by the federal definition, any place defined as not meant for human habitation. Yeah. So I started doing this work. Honestly, I got some exposure to street outreach when I was in my residency at Emory in I think it was 2008 when I first started or got introduced to doing any kind of street-based work. And it was an elective rotation that I sort of set up for myself with my mentor and supervisor at the time. So I went from like having no idea how to, it's like doing a cold call for a random person that you don't know and like striking up a conversation on a bench out in public with somebody who probably has no desire to, or minimal desire to talk to me or interest in sort of what I'm trying to promote. So I went from that in my residency program in 2008 to feeling, I guess, not only completely comfortable with, but actually skilled at, I really love the engagement piece of meeting somebody who doesn't know me and I don't know them, and going from kind of an introduction of just who I am as a person to that creativity of figuring out how to engage someone who's really maybe not interested in psychiatric care or not interested in me at all, to at least start to think about their overall health and wellness, and then hopefully to kind of through building a meaningful relationship together to be able to enter into psychiatric treatment if need be, or working towards working on a substance use disorder, or maybe even just kind of doing checkups every now and then to make sure that the person is surviving from a psychological standpoint all of the challenges that are involved with living unsheltered. So that's kind of my that's what I enjoy doing. That's a little bit about my background. I finished my residency in psychiatry in 2010. I did a fellowship in community psychiatry and got a master's in public health as a part of that, and have worked in a variety of settings as a psychiatrist, but with the continued kind of primary purpose of my work headed more and more towards both the direct clinical care involving street medicine and the broader kind of education and program development and advocacy towards improving the lives and health of people sleeping outside through work that I'm doing largely with the Street Medicine Institute.
Yeah, and Liz is one of those people. I want to say this very cautiously, but so the compliment comes through. Even though you're a very relatively young professional, it seems like this is your third lifetime doing this work, because it's just like there's certain people that just seem born into their professional life, and that's just one. I think from the first time I met you, it's like this woman was like created to do the work she's doing. So I just with our friendship and. I'm throwing it out there to put some pressure on you. Having read the first draft of the little book she's putting out that I'm really excited that the world gets to read at one point on street psychiatry. Just that the wisdom that you bring in, because what I've really come to appreciate from the street medicine perspective is somebody who's done a little bit of street outreach, but I know that there's a big difference in providing medical care on the street. And then there's a difference to provide psychiatric care, because if somebody's in pain, at least this is my perception, you can give them a pill to help their pain. There may be some motivation just biologically to do that. But I know with psychiatry, a lot of times the results are a little longer term. There needs to be some future thinking, that there needs to be managing of side. I mean, just reading that draft of your book, just like the complexity of what you do. And then I think the great examples of working through psychosis, dementia, and a whole lot of other range of mental issues, cognitive issues that you're working through, a lot of substance abuse issues. But I don't know, it just blew me away that something that I know is difficult just to do in an office setting sometimes, you're doing that on the street in a really cool, spectacular way. So I know when I'm always around you, I just feel like I get smarter.
Likewise. And I think you've outed me here on this book that now I'm going to have to actually finish it.
That was purpose. I knew it. It needs to get out into the world. So I want to talk to you as an expert on the harm reduction. I think anytime a successful street medicine program, at least everyone I've seen that I know is doing a good job out there, harm reduction is central to their thinking. I was exposed to harm reduction probably about 2003 or 4, ironically, after I got out of grad school for counseling psychology. I never got exposed to it through those 3 years or my undergrad work, which looking back is a little appalling in my opinion. But, it was in the HIV arena. And as I started, I got it really excited about, my first introduction is kind of meeting people where they're at. And I know we're going to talk about that's sort of the surface of harm reduction. One, I thought about, I look back many years later, it's like that we didn't think that way always. And, I was still like right at the beginning of my career, we were still making people be sober to get substance abuse treatment and some of those things that just seem ridiculous now.
Housing.
Yeah, exactly. But for me, I saw harm reduction being so, oh, it just fits so well with what I was learning about trauma informed care at the time as well. And so I wonder, as somebody who's done a deep thinking about harm reduction as far as bringing it in to your programs, I'd love to just maybe give us a working definition of how you see harm reduction and how it sort of informs how you look at delivering street medicine and street psychiatry.
Yeah, I mean, you're right. It's absolutely the foundation of any street medicine work, or should be,
Yeah.
and really should be at the foundation of any healthcare work.
I would throw mental health and substance abuse and education. Go ahead.
A lot of things, yeah. And I think in some sense, it stems from this idea that, as a physician in medical school, I took the Hippocratic Oath, and as a part of it, there's this sort of do no harm component. And so maybe it stems from that a little bit, but I think that my best working definition of harm reduction is really do less harm.
Mm-hmm.
And that sounds awful in thinking about, what kind of care do you want your doctor to provide for you? You want your doctor to do less harm. And I don't mean it quite like that, as the purpose of providing medical care or the way that we go about it is doing less harm. But I think it's we talk about this a lot in street medicine, that street medicine is both kind of idealistic and hopeful in many ways, but it's also firmly reality-based. And I think that the component of that makes street medicine so real and gritty is that when you are in the environment where the person is sleeping and you see that they have been sort of physically can't think of the word, confined. It's not combined, it's confined. Physically confined to a sort of makeshift mattress on the street because the person's hips are so deteriorated from their medical condition that they cannot move off of that without significant assistance from other people. And seeing and hearing that this person has to use the bathroom in discarded clothing that his friends then carry off for him because he can't get up to use it. It's impossible to ignore that reality in which a person lives. And in our clinics and in the spaces that we who provide healthcare work traditionally in our clinics, in our hospitals, and in whatever environment that we create, it's totally possible to ignore all existence of the outside world, and totally possible to ignore the reality of what all of our patients are living through, whether it's being out on the street or whether it's, Matt Bennett living in his living room or wherever you are. But, being in somebody's own environment tells us so much about who they are and what and just the reality of, like, is it likely that this person will take the medications that I give them based on kind of all of the competing needs within their environment, and whatnot. So I think that's kind of this focus on the reality basis is equally part of that foundation to harm reduction. And so looking at what reality is, we are then adjusting our interventions, be that, psychiatric treatment or wound care or working with somebody to decrease their substance use or even, getting them food stamps or into housing, things like that. We then adjust our sort of pie in the sky, this is sort of best medical practice, to what is required based on the reality of where somebody is physically, mentally, emotionally, spiritually, etc.
Yeah.
So sorry, I'm going on and on.
No,
but
no.
For
Well,
example,
and it leads to my, like, because I'm going to give away probably I don't think I've ever said this out loud, but I think I can do a really good job of faking like I know things. And so when I met you for the first time, and you said, because we were kind of talking and street psychiatry, and I can do a good job of kind of nodding like I know what somebody's talking about. And then I remember kind of going back and Googling it. It's like, okay, this woman is kind of a unicorn. Like, I just like, oh, there's street psychiatry. Because I think probably for a lot of our listeners, psychiatric care is just, I mean, even in sometimes good situations, it's something later on down the road. It's like, I know here in Colorado, sometimes we're scheduling appointments months out for people that maybe dancing on the edge of a mental health crisis or some sort or the other. It still can be kind of hard to get them in care until we get the 72-hour hold, because it goes into crisis. So what the thing that I always found fascinating is, it blows me away that surviving on the street, from what I know about neurobiology, I think you integrate this incredibly well into your thinking, is if I don't know where I'm going to eat, if I don't know if where I'm going to sleep is going to be safe, you throw the extreme example out there of the hip situation, and just the tragedy that human beings living in our culture have to live in those conditions. How do you treat mental health? Because it seems like from my perspective, it's like survival. If you go back to Maslow, I know Maslow's a little, but the basic needs are so neglected, and you're finding ways to get kind of into the mental health conversations. How the heck do you even conceptualize that for the person whose hip might be all jacked up beyond belief? How do you get them to think about anything involving their mental health?
Yeah, I think that's a great question. And I think it also, like, the question that arises from that for me is, how do you not address that for people sleeping outside?
Quit with the easy answers, Liz.
I think what we know is that a lot of people who become homeless have a mental health diagnosis that contributes to at the very least, the fraying of social relationships that keeps people out of homelessness.
Yeah.
But also the income and the ability to work and components of, finances that keep people out of homelessness.
Mm-hmm.
So what we know is that people experiencing homelessness are highly likely to have a mental health or substance use disorder diagnosis or symptoms of the diagnosis prior to becoming homeless. And then what's maybe not as well studied, there's sort of the chicken and the egg sort of thing, but that we know that the kind of traumas that people experience at minimum are essentially have the potential to cause post-traumatic stress disorder. So, but I think what we're saying is that a very large percentage of, at least in this country, people experiencing homelessness have some sort of symptoms of a substance use disorder, a depression, PTSD, a psychotic disorder, and then also a high proportion of people, I think, have personality disorders too. And then on top of that, I think there's another percentage of the population that even if they don't have any of those things, there are behaviors that are adaptive to the streets that are highly necessary for survival on the streets that don't translate to living indoors, and are therefore sort of maladaptive to living indoors. So even if, they don't have any of those other things that I treat in terms of, being a psychiatrist, just working on skill building and the ability to kind of build and repair relationships and grow trust. And then also kind of figure out that the challenges of navigating living inside, those are things that virtually everybody sleeping outside can benefit from. So how do we hope that people can become healthy and be able to live indoors? This is not to say that I think that all people experiencing homelessness are capable of living indoors already. It's just that the system isn't necessarily easy to navigate. But how do we create that environment for people to be able to thrive without addressing their mental health and behavioral issues?
Absolutely. I think like the chicken and egg analogy, that's where harm reduction really has been. I almost think about like it's one of those little angels on my shoulder that whisper in my ear whenever I think there needs to be a prerequisite for something. I think, that is one of those things that harm reduction is like, okay, early on in my career when I was doing a little bit of work in substance use, it was like we were the traditional 12-step where you had to be sober in order to get services. Well, which was sort of at least in the Midwest at the time, pretty mainstream to do. But, if you didn't have another paradigm, you never stepped outside of the box and asked, what about all those people who are using but want to be sober, but they just can't do that step? Another harm reduction approach is, with the housing first about, let's not expect somebody to be mentally healthy and totally sober and maybe even ready to work before we get them housed. Let's meet that basic need and then watch a lot of these other symptomatic things improve over time with support. So especially when I was reading the draft of your book, it just was one more reminder is like, I think, and I think some of us in housing kind of get into this mentality is like, oh, housing first. Like we've been and I love it. I think I'm a huge advocate for housing first. But, I think it's in some ways you challenge me to think about, well, maybe there's going to be a group of people that might be open to mental health services, psychiatric services, substance abuse services, but not open to housing. And how do we have the flexibility to meet them? So you're addressing in sometimes the mental health issues that might be preventing them from even seeing or being able to go into an enclosed space, even though we see that as a positive outcome. So that's one of the things, like harm reduction always challenges me to say, okay, even in this progressive housing first model where let's just get people housed because it's a human right, there still might be other ways that harm reduction can challenge us to be flexible in our thinking.
Right. And to be clear, like I think we talk about this a lot within the street medicine community, and as it relates to housing first, like housing first is great. And if we had free housing available for everybody experiencing homelessness in this country, I would be happy to be out of a job. Now, I'd probably still be doing home visits to those.
We would still need you, yeah.
Yeah, but I think the reality for most of us in areas across the U.S. is that the need for housing far exceeds the actual capacity of the housing. Yeah. And so the premise of street medicine is sort of like, well, what do we do in the meantime? People are dying out on the streets, and we can't ignore their health and other needs while they're waiting to have housing first.
Yeah.
And so I think that housing first and street medicine should go hand in hand. That, like, yes, absolutely, this person should go into housing immediately as soon as housing is available. And yet, sometimes it takes the establishment of a relationship for the person sleeping outside to be able to trust that person offering the housing in order for it to feel safe and acceptable.
Yeah.
So I think, you talked about Maslow's hierarchy, and I think, if I'm remembering correctly, the kind of very basic level of that hierarchy is safety, establishing safety. And so safety is not just in a physical sense, but also in a psychological sense, that people have to be and feel safe or trustworthy in order to move forward in other steps. And so while I view myself as providing very much a harm reduction version of psychiatry out on the streets, I think the most basic component of that is establishing safety more from like a psychological standpoint with a person to say, hey, I'm a safe person who is going to be there for you, even though I know that so many people in your life who were supposed to be there for you have not only not been there for you, but may have actually hurt you. That establishing that relationship is maybe the most important thing that I do for somebody's mental health and well-being.
Absolutely. Yeah.
Yeah.
And so when we think about, I want to kind of go off my harm reduction checklist because I'd love to get your thoughts on some of the key components. Because again, my thinking when I wrote Connecting Paradigms, harm reduction was just one of those things that's right there. In fact, I almost had to falsely separate it out from trauma-informed care because for me, it's been so ingrained in my healthcare for the homeless work and my HIV work, and now it just like is part of who I am. So a few things that I find, I just love to get your any additions that you have on this, because I'm sure not all of our listeners are as familiar with this. So one with harm reduction, I just love a little bit of the history, and I know I want to give you any kind of please expand this, but one of the things I loved about harm reduction is it was created by, and again, correct me, but people struggling with addiction. They called them, I want to be careful with my language here, but I think they termed themselves junkies. Am I correct? I think with that. But
I think some people identify as junkies, or
yeah, so it was that was
stigma of being a junkie.
Yeah, so it was their terminology, but they basically said, hey, the system doesn't work for us, and actually started to create their own system to help treat people who weren't ready for sobriety. They may have wanted that, but they didn't know kind of how to get sober enough to get into treatment. And so one of the concepts that came out as that compassionate pragmatism thing is to realize that negative behaviors have always existed in human history. And that has just been something to say, let's look beyond the behavior to see who we're dealing with. And that's like the history of harm reduction, I just think resonates is the system didn't see, and again, I'm using air quotes here if you're listening, the junkies as valuable members of society. However, they saw tremendous value both within themselves and in their peers, and actually found really successful ways to help people within that. So I just kind of wonder, I think there's something inherent about anybody that does street medicine to that, but just kind of how that practical pragmatism and kind of meeting people where they are at informs your work on the streets.
Exactly. And I think that's so true. I think that's essentially what we've been talking about, that, like I said, the forming that trusting, loving relationship with somebody out on the streets is kind of that first component, or that first kind of most pragmatic part, that like, how is anybody going to be willing to buy what I'm selling if they don't trust me, unless they're in crisis and they recognize that they're in crisis. And certainly there are folks who are experiencing suicidal ideation out on the street, and they've received psychiatric treatment before, and they know if they get on their medicines they'll be okay. Yeah, there are folks like that, but I think also there are folks who have some mental health or behavioral health issues and don't recognize that it's a problem, and that, again, if they're going to buy what I'm selling, which makes it sound really bad that I'm selling stuff on the street, but
drugs sometimes too, and a lot of hope.
They're going to buy what I'm selling, I have to show that I'm a trustworthy person, and building that relationship. A friend of mine, we had gotten a grant to take a look at how were we doing on a couple of different clinical measures in street medicine, and we were actually doing quite well, as I came to find out. But in the sort of first 6 months of the work that we were doing, we were screening and sort of measuring PTSD symptoms, post-traumatic stress disorder, for the people that we were working with. And then 6 months down the road, we looked at kind of what are their most recent scores on that same PTSD questionnaire. And what we had found is that we had improved in a clinically significant way symptoms of PTSD for something like 70 to 75% of our patients. And most of them were taking some sort of medication to help with their PTSD, but not all of them. There was sort of no way to explain our outcomes sheerly in looking at the efficacy of the medication. Like medication to treat PTSD just isn't that good. And so I was talking with a friend about it who had, not in the medical field, but had gone out with us on street medicine a few times and really loved it, and said, you know what I think it is? I think it's a love bomb that you guys drop on people. And that knowing that somebody loves them and cares about them and will be there for them is maybe the most important thing that you're doing to improve their PTSD. And it really kind of, I guess, gave some sort of framework for me to think about what I was doing on the street and harm reduction in a way that, like, I can reduce somebody's anxiety and symptoms of PTSD merely by being a positive presence in their life. And I think for that kind of pragmatism part of it, the other component, which I know you read in the draft of my book, is that I'm really not trying that hard to get people sort of non-psychotic or totally off substances or completely undepressed or completely not anxious. Like, I just don't think that's possible in the street environment. Although I have been surprised at how much better people can get in the street environment, and even seen some people have a complete, like, to have no further hallucinations even while living on the street, which I just think speaks to the resilience of the people that I'm working with. But I don't have those expectations of the psychiatric treatment. The expectations that I have are that even if we have housing first, or we call it housing first, there are still hoops that people have to jump through to get inside. And there are very specific things about mental health disorders and substance use disorders and cognitive disorders that really disrupt a person's ability to jump through those hoops, even if they have help. And so and what I'm kind of specifically talking about with that is that both depression and hallucinations and delusions, being high or withdrawing from a substance, having dementia, having a traumatic brain injury, which we know a ridiculously high proportion of people experiencing homelessness have, all of those impair cognitive function in some way. And the most prominent way they impair cognitive function is the component of executive function. And that is the specific part of your brain that does your sort of planning and thinking through and then carrying out your plans of doing something. And so if we think of all the steps that it takes to get your birth certificate, that's a multi-step process. And while somebody may be capable of completing any one of those steps, or we think that, all they have to do is show up to this place at this certain time, the process of, getting a bus pass and figuring out which bus to get on and getting off at the right stop, navigating the people in the, Social Security Administration office and getting told no, or saying that you need to have X, Y, and Z paperwork. Like, when we really think about what the whole process involves, and that's only one step in getting housed, that's just an insurmountable number of steps for somebody who has difficulty with planning and executing. And so my goal, this is long story long, getting to how I'm working on harm reduction with street psychiatry is that with the medications that I prescribe and with the kind of therapy that I do with people on the street, it's really aimed at how do I kind of glue somebody's brain together enough that they can start to have improved cognitive function and jump through those hoops with me.
Yeah.
And or with the social worker on our team or with whoever. But that, you know, it's not about really significantly improving their mental health. It's about improving their ability to get off the street.
Yeah. Well, and that's the other one of the big, I think, and challenges for, as we were kind of talking before we hit record on this, for even a lot of people, even maybe in the healthcare for the homeless, substance abuse. I mean, I run across, I know, I'm sure you do too, a lot of non-harm reduction folks in places you wouldn't think they might exist. But it gets that is, what does this person need? Because I think we can say we need to meet the person where they're at. I think about 99% of us could say that, smile, feel good about ourselves, justify that we're doing it. You know, when it gets, I think one of the common harm reduction approaches is something like needle exchange. You know, which is a common one, and I think too often we just talk about needle exchange as harm reduction and don't expand it out. But
needle exchange and condoms.
Exactly.
That's what most people think about.
Exactly. And you know, with needle exchange, I'm just, you know, this has been a few years back in Denver, fairly liberal city, I would say more liberal than most, takes pride in that for the most part. I heard city council members say some things that I was appalled by when it came to needle exchange. It's still like this, there's something about our cognition of, if I give someone a clean needle, they're going to use. Whereas if we don't give them a clean needle, they're not going to use. Now, you know, the research shows the exact opposite. It's true. And I think where we miss with a lot of harm reduction sort of gets demonized by certain people who may not have seen the research more than anybody else. Because you look at the research, harm reduction works. It's like, you know, it's the relationship, right? It's the fact that you're coming in and I understand that you're going to use, you know, you're going to use. I want to give you an ability to, and this is where my thinking of harm reduction has really, I think, evolved over the last few years. If I'm reducing harm, and that may be harm for hepatitis, HIV, you know, whatever that might be, but I'm giving you an opportunity to increase something you mentioned is safety. So I've really thought about, as when we talk about trauma-informed care, we talk a lot about physical and psychological safety. Physical safety is kind of I think a lot of people get that. Psychological safety, which you've talked about with the love bomb. It's like, hey, I'm going to meet you where you're at. I may want you to stop using eventually, even though I may not verbalize that in the first 3 or 4 months. You know, that might be my goal in the back of my head. But if I can engage you and I can increase safety and reduce harm, what opportunities do I kind of open up to integrate other services like housing, like other medication? And so it's that relationship between safety and harm that I think is where the power of harm reduction and what drives these great outcomes really lies. And I just would love to get your opinion on that kind of relationship between harm and safety.
Yeah. You're not asking easy questions here. These are easy questions, and these are not easy questions.
Hey, when I get smart people, I don't ask the easy questions.
Okay, so back up. The relationship between safety and
harm. So I guess my argument is, one of the things why harm reduction seems to work, whether it's, you know, getting somebody in housing, even though they may still be using, whether it's a needle exchange, whether it's giving out condoms, why we see it is, one, when people feel, we build that psychological safety and physical safety. So I guess maybe let me phrase this in the form of a question for you is, My theory is, so your opinion is, the more we decrease harm reduction, the more we increase safety, which then hopefully leads to better outcomes later on.
Right.
And so, yeah, well, what are your thoughts about my harm to safety equation?
Yeah, I think I think I agree with your equation, that that better outcomes in the future is sort of what we're aiming for overall with harm reduction. That in reducing harm we improve safety, and then there are some sort of eventual lofty goals that we hope to get to eventually. But right now we're just going to prevent people from dying. We're going to prevent people from getting HIV. We're going to prevent, people from getting hepatitis C, etc. We're going to prevent people from dying of respiratory failure because they take too much heroin or there's fentanyl laced in their heroin, things like that. And so, yes, we have to establish safety before we can get to those eventual goals.
Or as you point out, to keep them alive is really good.
Yeah, if somebody's dead,
outcomes.
I'm never going to get them off substances. Although maybe I have because they can't physically use anymore. I don't know. But like to some extent, I think the as you were talking, I was reflecting about maybe the difference between the folks on the city council or whoever you were talking about in Colorado, that they kind of had a different outcome that they were hoping for. And so the outcome maybe in the world of homelessness and homeless healthcare and whatnot is the goal of a lot of organizations is ending homelessness, getting people off the street. And yes, absolutely, that is a goal that I am aiming for. I would love to see people no longer experiencing homelessness in the United States. And yet, that is something that we have been working on for decades. And what we know in the meantime is that people are suffering and people are dying and people are hurting. And in that meantime, while we try to end homelessness. And so my immediate goal is not how do I end homelessness or how do I get people off the street. My immediate goal is how do I keep them safe and healthier, so that they will have the ability to thrive once they get into housing. That I don't think it's possible to thrive on the streets. I think it's only possible to survive on the streets. But how do I, and also thinking about like, how do I help people not become homeless again once they've gotten into housing? Because I think that, I mean, a lot of the housing first, data out there shows a very high retention in housing. And I think what we've learned from that is there is a specific subset of the population. I mean, the people that they worked with in Housing First, the initial studies, were people with psychotic disorders who largely spent most of their time isolated on the street and did not have a lot of social connections. They had a very intense assertive community treatment team working with people as they transition them into housing, where the client to staff ratio was 1 to 4. And they had a very intense amount of continued contact over a somewhat indefinite period of time, because according to that ACT model, you could never fall out of care, you could never be dismissed from care with ACT once you got on. Now, ACT has changed somewhat in the way that it's being administered, but I think, yeah, if you give 40 people or 100 people that kind of attention who didn't have these other sort of, who are gonna, like, people who isolate outside where they're sleeping are gonna tend to kind of isolate inside where they're sleeping. And in studies, those folks tend to do great in housing, but it's the very social substance users who have maybe the hardest time staying in housing, because you put them in a place where they have no social connections and no support. And even if some of those social connections and support were maybe not the healthiest, they still helped people survive. And so you take them out of the environment in which they have all these resources, and it is so hard to help them stay in housing, because housing doesn't meet their needs it doesn't meet the variety of needs that they have. It only meets one need, which is a roof.
Exactly.
So how do we, so with the goal of ending homelessness for good and not having people return to the streets, I think we have to lay the groundwork both for having people alive by the time their housing is available, but also giving them the resources to develop a new skill set within their housing to survive and thrive. And that's what harm reduction with regard to street medicine and healthcare for the homeless, I think, really should be about. And so I'm answering a little bit different question from those council members that, like, I want to end homelessness, but I also want to not have dead people on the street.
Right. Exactly.
So how do I prevent people from dying?
Well, the interesting thing that I'm seeing now in my trainings are a lot of times, and I find this because one of the things harm reduction reminds us of, I believe, is how complex our work is. I don't think it's not just sticking somebody if we had enough affordable housing, just putting someone, as you did a great job of saying, for some people, just sticking them in a place where they can self-isolate, that's going to bring on a huge sense of safety for that small portion of the population. But then you have all these people who have maybe survived for decades out on the street in a group, and you isolate them, and that can bring on a sense of danger or threat. Is
right.
It's how do you manage safety within those environments when you have all this stuff going on? Because some of the biggest critics of harm reduction now are people in harm reduction type of housing first programs to say, I don't feel safe because all my neighbors are getting high every day and I'm trying to kick my habit. So it's just this fascinating, it just shows the challenge. And like I said, it's like, how do you keep everyone feeling safe when you've got everybody in your housing program, especially if it's in a centralized location and not kind of scattered apartments, feeling safe in that environment, while some people might be still using, others are maybe in a different spot with a recovery or their sobriety. And it's not easy work.
It's incredibly complex, and I don't think we have all the answers. And
right.
But that's okay.
Yeah.
Okay. We're working on it.
Yep.
And that's kind of a harm reduction approach to ourselves as well.
Exactly.
That, it's okay that we are where we are, and that we're still going to work on improving.
Yeah. So I got one more question I got to squeeze in here. And it's kind of one of those Matt questions, but one of the things, so in harm reduction, there's this kind of mantra, and whenever anything gets mantra, it probably loses some of its original, but we're meeting them where they are at, right? And I love that compassionate pragmatism. I like it is because historically, and when I was trained, we sort of expected people, while we still do, you made a great thing with the birth certificate, to jump through our hoops. In other words, you will succeed in our program if you jump through all our hoops and do exactly what we ask you to do. We now, I think, have evolved to say, hey, we need that flexibility. Where I see harm reduction and trauma-informed care so intertwined is around the neurobiology of folks. Like, to me, the challenge where these two things just overlap and almost just the DNA of trauma-informed and harm reduction are just so intertwined, is that we really, when we understand the neurobiology of trauma, you mentioned traumatic brain injury as well, when we understand the connection even with epigenetics and chronic, all this different sciences, to me, one of the challenges harm reduction gives for us is how do we create programming, how do we create interventions, treatments that really match the neurobiological state that the folks we're meeting are in. And I believe you've done an amazing job of taking, and again, I'm not a psychiatrist, so any psychiatrists out there, just email me and tell me I'm wrong. And Liz, you can do it. It's like so much of my thing about psychiatry is setting up somebody an appointment 2 months from now, they get to go in for maybe a half hour. And in that time, they get a diagnosis and walk out with a very powerful medication that we keep our fingers crossed is right. You know, you've taken that model and I think done just an amazing job of customizing that intervention for folks with a very different neurobiology than what is typical kind of in the medical arena. And I just kind of wonder, as you approach someone on the street, how do you find that magic space to connect with them, find a starting point, and maybe even just broach the psychiatric intervention. So how do you do sort of that magic, knowing the next person you're going to talk to is coming from a whole different place?
Mm-hmm. I think it starts with, and this is what I was thinking about when you were talking about harm reduction and trauma-informed care and where people are in their neurobiology. Like I love kind of the idea is to expand a person's window of tolerance so that they're neither in a hyper or hypo arousal state, but that we're going to widen that window of tolerance, because in the window of tolerance, people have the best sort of brain capacity to think and be creative and plan and follow through with things. That in order to really do that and get to where they are, not just by meeting them on the street in a physical location, and not just kind of recognizing what stage of change that Prochaska and DiClemente identified that somebody might be in, not just sort of recognizing those superficial things, but developing a really sort of deep empathy and openness to who the person is and what they're telling you about themselves. And I think it's only when we approach people with that willingness to listen and to just be with a person, rather than approaching it from a I'm going to help you standpoint, that approaching with a I want to get to know you and I care about you as a human being. That approach is what gets us to figuring out where they are at in a deeper level. And I think, you know, a lot of times I approach people that I don't know and they don't know me. And the first thing I'll do is ask permission if I can sit down and talk with them, and get to know them. And most people will sort of be like, okay, whatever. I'm not like, I don't really care if you do or don't, but like, whatever. There are a few people who will curse me out just for asking, and a few people who will tell me their entire life history just for asking that. But I think the hardest thing that we do as clinicians is just to sit and be in silence with people even. But I will offer sort of things to get the conversation started. And a lot of it's just based on kind of my, I don't know, reading of their mood at that point. I like to think that I'm fairly receptive, or that I can detect those things, a person's sort of mood and whatnot, relatively easily. But to take it from like, you know, whether this is the approach that I need to to say, hey, I brought this snack bag for you, or hey, I brought these socks for you. And when's the last time you were seen by a doctor? And did you know that you're supposed to get a checkup every year from your doctor, even if you think you're totally fine? And do you know it's also a good idea to get a checkup from the neck up every so often? Whether I approach with that, or whether I kind of sit there and say, you want to see a picture of my kid?
Yeah.
Or something like that. Or just kind of ask them, I don't know, like, what do you think the weather's going to be tomorrow? Like, it sounds like a stupid way to start a psychiatric evaluation. But like, my goal isn't to do a psychiatric assessment when I sit down with somebody initially, but it's to understand who they are and really what's important to them, and what do they ultimately need? What do they see as their needs in being able to do the things that are important to them? And it's in discovering that, a person has a 12-year-old child that they haven't seen since, labor and delivery, that they're desperate to have a relationship with, but they can't because they can't stay sober for 2 hours. And may not even recognize that that's the biggest problem in it. But like, to know what somebody's sort of heart's desire is, and to help them work towards it in whatever way seems like it'll work the best. And I'm not even pretending that my way is the best way or the only way. I do think that psychiatric medications or antipsychotic medications will help somebody have fewer hallucinations. I do think that not smoking crack on a daily basis will help somebody have fewer hallucinations. But I am also open to a future in which somebody continues to have their hallucinations, but is still able to have some contact with their 12-year-old son.
Beautiful.
Now, if I that has to be okay too.
Yeah. And if I was a smart man, I would let that be the last word. But I just have to ask you one more. Oh, this is such a tiny question. It'll be so easy to answer. But the medical model has gotten some bad press lately in the trauma world. And I think a lot of that had to do with the revisions to the DSM, and a whole lot of people, Vanderkalt was kind of leading this movement to look, especially with trauma, post-traumatic stress disorder, looking at more developmental than symptomatic. And so there's been this really pushback, and with psychiatry being, the APA being a big, behind the DSM, I wonder, because everything you just said seems to be from a layman's perspective who has not been to medical school, not what I would think about as the traditional medical model of a very sterile sort of symptomatic diagnosis. So I just kind of wonder, as a small last question, Liz, for you, like, what do you think about sort of what's going on with the medical model? How do you think about that? Is what your answer is kind of how you adjust that for your population? Just kind of as somebody who's trained in that model, who's getting some bad press, probably too much, because when we label something, we just throw too much underneath it. But I'd just love to get your opinion about, the medical model of treatment in general. How do you just kind of dump that for street medicine? Do you customize it? Sort of, how do you use that educational background you have in that model out on the street? So if you could just indulge my intellectual curiosity.
I mean, I think I am trained under a medical model. My training, and this is very much like medical education, I feel like, is that you see somebody with symptoms, they come to you with symptoms. Yes. That's number one. They come to you with symptoms in one way, shape, or form. You figure out what the cause of those symptoms are and give it a name. And then you treat those symptoms, or that named thing that's causing the symptoms, with, be it medication or surgery or therapy or some sort of, you prescribe a treatment for someone and they get better. That's
Yeah.
sort of the idea, or they're supposed to get better. And so yes, that's a model that I follow. And in my, like, if you were to look at my medical record for the people that I treat out on the street, you would very much think that I am just using that model completely.
Yeah.
But what medical school doesn't teach you, lo and behold, is that it doesn't teach you how to be a human being. It doesn't teach you how to relate to people. It doesn't teach you how to cause wellness in people. It teaches you how to cause the absence of disease or to achieve some amount of remission of the disease. And so, yeah, I use that model to treat my patients and to write my notes, and I know kind of what the right medicines for X, Y, and Z diagnoses are. But I don't let it prevent me from being a human being too. Because what people, not only on the streets, but all of us need from our healthcare providers is somebody who will treat them like a human being, who has hopes and dreams and goals and desires, who will help them achieve those by reducing the burden of illness or improving the ability to function. So, I mean, I don't see them at odds of each other, but I think that the medical model is just a small part of the overall kind of what it takes to be a doctor or what it takes to be a clinician. And we can't forget that. It's just one tool in our belts.
Thank you for saving my butt and ending that question with just as much inspiration as the last one. So, Liz, this has been a great conversation. I feel like we could go down about 8 or 9 other pathways with this. So I appreciate your work. I'm sure my audience will agree with me. It's just too bad cloning hasn't evolved to the spot where we could have a Liz, at least one Liz in every community, if not a dozen or so for us. So, Liz, I know you do a lot of work in street medicine in general. Do you want to just, I'll put some information in the show notes, but if people are interested in street medicine, where would you, I know you do so much great advocacy around this and work, where just for our listeners who may not be on the website, what would you suggest some resources out there for them?
Yeah, so it's easy for the website. It's streetmedicine.org. That'll take you to the Street Medicine Institute's website. And on there, currently it's free to become a member. So you can just become a member and have access to the entirety of our website and resources, which also includes resources both for doing street medicine work during the COVID-19 pandemic and resources for building resilience for it's geared towards a street medicine workforce, but it could be easily applied to a healthcare workforce during the pandemic, in terms of, building psychological and emotional support and wellness for healthcare providers facing all of the challenges that it takes during the pandemic. And then there are a whole host of other things like kind of alternative clinical guidelines that are geared towards, okay, this is the standard of care and this is how it may or may not work based on the street setting. Like, you don't want to make somebody pee all the time with their hypertension medicine if they're sleeping outside and don't have access to a bathroom, things like that to consider. So there are a bunch of resources, streetmedicine.org. We're also on Facebook, and I think if you just Google street medicine, it should be kind of one of the first things that pops up.
And at this point, the book will be on streetmedicine.org at some point as well. Is that still? At
some point as well.
Well, if nothing else, I learned a lot from reading, and I just want to thank you for all the great work you do. And one of the reasons I'm cheerleading the book is because, I think for a lot of us who didn't go to medical school, medicine's just this sort of mystery in and of itself, and we appreciate the complexity. But to actually, what you do in the book that's so great is you walk us through an interaction. I don't even want to call it a visit per se, but just how you assess, diagnose, and you don't give yourself the easiest case either. You put the psychosis, schizoaffective stuff going on, and just to see how you work with that to help people find that next step in their life, which is hopefully, again, increased safety, less harm. I mean, it's just a beautiful thing that you do. So I appreciate you so much sharing this with us. We'll put some of your contact information and stuff in the show notes as well. And Liz, I want to thank you so much, my friend, for your work and your time.
Thank you for inviting me. This was a pleasure.
All right. As always, friends, you can find show notes at traumainformedlens.org, and we'll see you soon. Thank you.